Sideroblastic anemia. What happens is the patient gets anemia because the RBCs, the precursor RBCs, cannot utilize the iron that is already present in the body to form hemoglobin. So in such people, hemoglobin level, the iron is there in the body, but RBCs cannot utilize that iron to make hemoglobin. So in sideroblastic anemia, you have to remember that these are RBCs, right? And you can see these bodies, right? They are called as Pappenheimer bodies. They are small iron containing granules that are present in the RBCs. Right, so Pappenheimer bodies, where do you see? That's all you should know, that you see in sideroblastic anemia. Now next, tell me about megaloblastic anemia. So it is anemia caused because of vitamin B12 deficiency or folate deficiency, and this can lead to defective DNA synthesis, right? And also you're going to see large RBCs. See, for proper division of RBCs, we require vitamin B12. What is the other name of vitamin B12? Very good, it is called as cobalamin. And we also require folic acid, which is vitamin B9, folic acid. Okay, so if either is deficient, vitamin B12 deficient ആണ്, അല്ലെങ്കിൽ folic acid deficient ആണ് എങ്കിൽ, DNA in the RBCs, it cannot be made properly. The cells cannot divide normally, so the cell will keep getting bigger, but it'll try to divide, but it cannot divide. So as a result, what you're gonna see abnormally large RBCs, right? And these abnormally large RBCs in the bone marrow, they have a name called as megaloblast. So abnormally large RBCs in the bone marrow, I call them as what? Megaloblast. So we'll quickly see what are the changes we see, or what are the things we see in peripheral smear in megaloblastic anemia. You're going to see macroovelocytes. You can see these large oval RBCs. You can see hypersegmented neutrophils. See, neutrophil normally it has got 3 to 5 lobes. Okay, but you can see here there is more than 5 lobes here. Why so? See here in megaloblastic anemia, what happens is, I told you the DNA synthesis is defective, right? So the DNA synthesis happens in all cells, including the neutrophils. So the nucleus develops abnormally and gets too many segments. So you get to see even more than 7 lobes. So what I mean to say is megaloblastic anemia, I told you the defective DNA synthesis, it is not just in RBCs. RBCസിൻ്റെ മൾട്ടിപ്ലിക്കേഷൻ മാത്രമല്ല ഇവിടെ ഡിഫക്റ്റീവ് ആവുന്നത്, ഈവൻ ദ ന്യൂട്രോഫിൽസ്, ഈ റാപ്പിഡ്ലി ഡിവൈഡിങ് സെൽസിൻ്റെ DNA synthesis എല്ലാം എഫക്റ്റഡ് ആവുകയാണ്, ഇൻക്ലൂഡിങ് ന്യൂട്രോഫിൽസ്. സോ സി ദീസ് സെൽസ് ഓൾസോ വിൽ ട്രൈ ടു ഡിവൈഡ്, ബട്ട് ദേ കാൺട്ട്, ആൻഡ് ഡ്യൂറിങ് ദാറ്റ് പ്രോസസ് ദെയർ ന്യൂക്ലിയസ്, it will develop abnormally and gets too many segments, and that is called as hypersegmented neutrophil. Now another feature you see in megaloblastic anemia, that is teardrop cell, right? Now teardrop cell, the other name is dacrocytes. Very important, dacrocytes. Okay, they are not classical hallmark of megaloblastic anemia. These teardrop cells we can see in other conditions also. We can see in myelofibrosis, we can see in bone marrow infiltration. So remember, you see a teardrop cell, don't come to a conclusion that okay, this is megaloblastic anemia. There are other conditions also where you see teardrop cells. Now next question is, which test will you use to find out the cause of megaloblastic anemia? Which test will you use? Very good, it is Schilling test, right? So this is a rapid revision video. So in most of the videos from now on, while we're preparing for the competitive exams, just before the exams, I'll be telling you just the one-liners. So in detail we'll talk later. There is a reason, or you have to know how we do Schilling's test, what is the principle behind it. But most of your competitive exams, they focus on your memory power. So just remember, megaloblastic anemia, it can happen due to multiple reasons, and to find out the cause of megaloblastic anemia, you do Schilling test. Now first question, you identify what is the disease. What is your diagnosis here? Very good, it is pterygium. Okay, now pterygium, you can see it is a triangular fibrovascular growth of the conjunctiva that can extend into the cornea, and this happens in the nasal side. So here it's going to be the nose, right? So it usually occurs on the nasal side. So they will describe it as a wing-shaped fleshy tissue growing from the conjunctiva onto the cornea. Why does it happen? Can happen because of sunlight, dust, dry climates, and nasal sidalana. It is most commonly seen, and the patient is going to complain of foreign body sensation, irritation, cosmetic concern. Now, another question they ask is, what is Stalker's line? Write it down. It is a PYQ. What is Stalker's line you see in pterygium? See, it is a brown iron deposition seen in the head of the pterygium. So it's not very evident here. You can see brownish. Let me take a brown color. Where is brown color? So it is a brown iron deposition seen in the head of the pterygium. So why does it happen? This pterygium, this growth, it alters the tear film. Okay, so the iron from the tear film, it gets deposited in the corneal epithelium. That is why. So all they ask you is name. That is all you should know. Stalker's line, that is brown deposition of iron, brown iron deposition seen on the head of the pterygium. Now you will tell me, it is unrelated to pterygium, what is Fleischer ring? What is Fleischer ring? It is iron deposited on the cornea. Iron deposited on the cornea. It is seen in which condition, guys? Keratoconus. Okay, now look this picture very carefully. Don't get confused. We were talking about Fleischer ring. Fleischer ring, it is seen in keratoconus. You know what is keratoconus, right? It is when the cornea becomes cone shaped, right? Bulging. So the iron gets deposited around the base of the cone and it looks like a brownish ring. That is called as Fleischer ring. It is seen in keratoconus. This one, first picture that you're seeing. The second picture that you're seeing, that is Kayser-Fleischer ring. What is Kayser-Fleischer ring? Very important. It is the copper deposition in the cornea. Which layer of the cornea? Descemet's membrane, and it is seen in Wilson's disease. This is Kayser-Fleischer ring, where copper is deposited in the cornea, right? Okay, now you will identify what kind of ulcer it is. That is fungal keratitis. So fungal keratitis, it is infection of the cornea caused by fungi, and they will give a history. They will say that the person had trauma with a vegetative matter, like a plant, or it could be sticks. So they'll give this history. First thing that should come to your mind is what? It is a fungal infection of the cornea. Common organisms, you can say Aspergillus, Fusarium, Candida. All these are the organisms which affect the eyes. Now, what are the features of fungal ulcer? See, it's going to be a dry looking ulcer, okay? And the margins, it is going to be irregular. They will give feathery appearance. The margin is going to look feathery, okay? Meaning irregular. The edges are irregular. That is the meaning. And there is going to be hypopyon. This that you see here, that is hypopyon. That is nothing but pus, okay? In the anterior chamber, that is hypopyon. And another feature they will give you is there are going to be satellite lesions. Now, where are the, what do you mean by satellite lesions? See, you can see this big ulcer here. This is fungal keratitis, okay? And around the big ulcer, you can see small infiltrates. Can you appreciate these small infiltrates here? Yes, they are called as satellite lesions. So, satellite lesions means these are small daughter lesions around that are seen around the main ulcer, and it strongly suggests, if you see satellite lesions, it strongly suggests fungal keratitis. Now, another thing they ask is, in fungal keratitis, how is the hypopyon? See, this is the hypopyon, right? So you will say it is non-sterile and it is going to be immobile. Non-sterile and immobile. What is the treatment? The treatment is natamycin 5%, eye drops, right? So these are the important points in fungal keratitis. Okay, now one question. Tell me, what is hypopyon? Okay, you spotted hypopyon here, this one, but what it is? Hypopyon means a collection of WBCs, pus, that is in the anterior chamber of the eye. So it can be seen as what? A white fluid at the bottom of the anterior chamber. Now, remember, In bacterial ulcers also you get to see hypopyon. There it is going to hypopyon, it is going to be sterile and it is going to be mobile, meaning okay, the bacteria are in the cornea but they have not entered the anterior chamber. Okay, so the hypopyon, when you examine in a bacterial ulcer, it is the hypopyon will have inflammatory cells, it will not have any organisms. And also the hypopyon and bacterial keratitis, it is going to be mobile, means when the patient is lifting or tilting his head, when he is moving his head, the pus level will also shift, right? In fungal keratitis, remember, in fungal keratitis you are just going to remember no. Okay, if I'm asking you, is the hypopyon sterile, you're going to say no ma'am, it is not sterile, right? Non-sterile means the fungal organisms can be present within the hypopyon. When you examine the hypopyon in fungal keratitis, the hypopyon here, what you will see, the fungal organisms can be actually present here. That is why I said it is not sterile. Next, it is, now if I'm asking you, in fungal keratitis, is the hypopyon mobile, does it move? Again you're going to say no. You're going to say no ma'am, it is not going to move when the patient changes his head position, right? So yeah, that is important point. In fungal keratitis, the hypopyon, it is non-mobile and non-sterile. Now you tell me what kind of ulcer it is. It is a corneal ulcer. What do you call this ulcer? Yes, very good. It is a dendritic ulcer. A dendritic ulcer, it is caused by which organisms, guys? It is caused by HSV. What is HSV? Herpes simplex virus. So you can see this branching ulcer in the corneal epithelium, that is called as dendritic ulcer. Dendritic means, you know what? It means tree, like a tree. So these branches look like a tree. That is why it's called as a dendritic ulcer. The most common cause is herpes simplex virus, HSV1, herpes simplex virus. And remember, they will ask you to, or they might give in a sentence, how these dendritic ulcers look like. So these are branching ulcers, right? They look like branches, and at the end they have got terminal bulbs. That is how they look. At the end they have got terminal bulbs, and we stain it with a fluorescent dye, right? And remember, in dendritic ulcers, the corneal sensation, it is decreased. Therefore, it is going to be a painless ulcer. Another important point, it is going to be a painless ulcer because the corneal sensation is decreased. Now, one question. I told you HS, herpes simplex virus, it causes terminal bulbs. Okay, there are dendritic, or I'll say that there are branching linear ulcers with terminal bulbs. Okay, now my question is, where do you see pseudodendrites, meaning where do you see similar pattern but there is no bulbs at the end? You will see a tree like ulcer only, but there are no, see here in HSV I told you at the end there are going to be terminal bulb like appearance. But in another disease condition, again it looks, the ulcer looks like a tree like pattern only, dendritic only, but at the end there are no terminal bulbs. Can you tell me which organism causes that kind of ulcer? Very good. It is caused by herpes zoster ophthalmicus. Write it down. So pseudodendritic ulcers, they are caused by herpes zoster ophthalmicus. So don't get confused. Okay, herpes simplex virus, it causes dendritic ulcer. Herpes zoster ophthalmicus, it causes pseudodendritic ulcers. സി സ്യൂഡോഡെൻഡ്രൈറ്റിക് അൾസർ എന്ന് പറഞ്ഞാൽ ഒന്നുമില്ല, സെയിം തിങ്. ആ ഒരു ബ്രാഞ്ചിങ് പാറ്റേൺ ആയിരിക്കും അൾസർ, പക്ഷേ എൻഡിൽ ആ ഒരു ടെർമിനൽ ബൾബ്സ് ഇല്ലേ, ആ സ്ട്രക്ചേഴ്സ് ഉണ്ടാവത്തില്ല. ഈ ടെർമിനൽ ബൾബ്സ് ഉണ്ടാവുകയാണെങ്കിൽ എന്താണത്? HSV ആണ്. ടെർമിനൽ ബൾബ്സ് ഇല്ലെങ്കിൽ അത് HZO, herpes zoster ophthalmicus ആണ്. സിമ്പിൾ. റൈറ്റ് ഇറ്റ് ഡൗൺ. ഇറ്റ് ഈസ് കൺഫ്യൂസിങ്. ഓക്കെ, നോട്ട് കൺഫ്യൂസിങ്, ഇറ്റ് ക്യാൻ ഗെറ്റ് messed up if you don't revise it and go. Now identify this kind of ulcer. You can see this is called as a ring ulcer. Where do you see ring ulcer, guys? You see it in contact lens users. Okay, and it is because of which organism? Acanthamoeba. So these are the important points. Acanthamoeba. Okay, and is it going to be painful or painless? It is going to be too painful. It is going to be too painful. And what is the treatment here in Acanthamoeba keratitis? You have to remember PHMB. Okay, that is polyhexamethylene biguanide. Polyhexamethylene biguanide. You just have to know PHMB. That is enough. So let's revise it again. It will come as an image-based question. Acanthamoeba keratitis, it is seen in contact lens users where they use contaminated water or for cleaning the lens, or poor lens hygiene. Those people tend to get this kind of ulcer. And here one of the history they are going to give is they are going to have pain that is very disproportionate to the clinical finding. It is going to be extremely painful. All you maybe see is a ring ulcer, but the patient is going to cry loud in pain. Now, ring-shaped ulcer, that is a classical feature, clinical finding that points towards acanthamoeba keratitis. Now, quickly you will tell me about eye ulcers. If you see dendritic ulcers, what is going to be your thought? Dendritic ulcer, you're going to think about herpes simplex virus, right? You're going to see satellite ulcers, satellite lesions, and feathery margins. You're going to think about fungal keratitis. Am I right? And if you see a ring ulcer, and if the patient is going to say he has lot of pain, then you're going to think about acanthamoeba keratitis. So these are the buzzwords.